Sorry about that hitch. Okay, so we'll just start this off again because I don't think anyone saw the slides. So today the topic of discussion is management of non-oncogene addicted metastatic non-small cell lung cancer. So when you talk about the management, it started off with chemotherapy, right? So chemotherapy was basically platinum doublet, and the platinum used was initially cisplatin, and then there was systemic reviews and meta-analysis which looked at cisplatin versus carboplatin, which found that both were equivalent in outcomes. So carboplatin and cisplatin became interchangeable. Then they looked at adding a third drug, which had no benefit. And then they found that pemetrexed had an added advantage in adenocarcinomas when combined with a platinum agent. So the treatment of choice essentially became platinum plus pemetrexed in adenocarcinomas and platinum plus paclitaxel or nab-paclitaxel or gemcitabine in squamous cell carcinomas. So so that is the current standard of the chemotherapy backbone. In adenocarcinoma is platinum plus pemetrexed. In squamous cell carcinoma is platinum plus either one of these three agents. So why pemetrexed in adenocarcinoma? We have a phase 3 trial. This particular phase 3 trial was by Sclagotti et al. And it looked at platinum plus gem versus platinum plus pemetrexed. And in the adenocarcinoma subgroup, they found that there was an OS benefit when giving platinum plus pemetrexed. So this benefit is seen only in the adenocarcinoma subgroup because we know that pemetrexed inhibits the enzyme thymidate synthetase, right? That is the main mechanism of action. And this thymidate synthetase is overexpressed in squamous cell carcinoma, which is why it cannot be effectively inhibited, which is why pemetrexed is ineffective in squamous cell carcinoma, and the benefit is seen in adenocarcinoma. So that is why we have these chemotherapy backbones, which are different in adenocarcinoma and squamous cell carcinoma. So although we had chemotherapy, the benefit, the quantum of benefit is only to the tune of 8 months. So we looked at ways in which we could improve that benefit. So number one was starting off with the platinum plus platinum based doublet and then continuing the same agent. Okay. So one of the maintenance strategies was with gemcitabine, where post platinum plus gemcitabine, they continue with gem maintenance, 1 gram per meter square, day 1, 8 every 21 days versus placebo. And here they saw a PFS benefit by giving gemcitabine maintenance. Trial. And the Paramount trial benefit and post platinum plus pemetrexed maintenance became a standard for adenocarcinomas. Okay. Then the third maintenance approach was with bevacizumab. So just like the pemetrexed maintenance, this was only in adenocarcinomas. This is only approved in adenocarcinomas. So what they did, this was the ECOG 4599 trial, and it looked at bevacizumab. So it looked at carbo plus Pacli plus bevacizumab. So I'll just spell it out. Versus carbopacli followed by bev maintenance. So it's not purely a bev maintenance trial, but it also included bev maintenance, right? And this trial, it was done in adenocarcinomas because phase 2 trials had shown that bevacizumab causes severe bleeding diastasis like hemoptysis in around 15% of the patients when given in squamous cell carcinoma patients. So bevacizumab should always be avoided in squamous cell carcinoma patients. It was tried in adenocarcinoma specifically because there the bleeding diastasis was a bleeding side effect was not that commonly seen. So carbo plus pacli was bevacizumab followed by bev maintenance was carbopacli alone showed a PFS as well as an OS benefit. So these are the three maintenance approaches. Um you can give gem maintenance post platinum plus gemcitabine. You can give pemetrexed maintenance post platinum plus pemetrexed, and you can give bevacizumab maintenance post carbopacli plus bevacizumab. Right. So post that you can continue bevacizumab as maintenance. So these are the same maintenance approaches. Then you have the switch maintenance approaches where you gave a platinum plus sorry a platinum plus a particular drug, right? Then you gave a completely different drug as maintenance. So another drug as maintenance, which is not given in the initial arm, platinum based doublet. So in this setting, we have a few trials that were done. So you have the JMEN trial, which looked at platinum doublet. So a non-pemetrexed platinum doublet followed by PEM maintenance versus placebo. So the platinum doublet did not contain pemetrexed, but in maintenance you started giving pemetrexed. So there's a switch of the drug, right? And that showed a PFS and OS benefit. That is the JMEN trial. Okay. Then you had the Saturn trial. And in the Saturn trial, they gave once again platinum doublet. Right. They gave the platinum doublet. And then they switched over to erlotinib 150 mg OD. So there's this was done. There was some the earlier data. People thought that erlotinib worked regardless of driver mutations. This was before the discovery of before we characterized these driver mutations. So erlotinib was tried as switch maintenance post platinum doublet versus placebo, and there was a PFS benefit that was seen surprisingly, which is significant. Then the third trial is the IFCT trial, where they gave Gemsys and then they switched over to erlotinib versus placebo. And this also showed a PFS benefit, which is significant. So these are the switch trials. You have the JMEN, Saturn, and IFCT trials, right? Which switched to an agent that was not used in the initial induction arm. Okay. So those are the switch maintenance techniques. And then you have the combination maintenance technique. So in this setting, you have two trials. The Atlas trial, right? So here they gave platinum doublet plus bevacizumab, and this was followed by bev maintenance versus bev plus erlotinib maintenance. So you're using combination maintenance here, and basically there was a PFS benefit that was seen here. And then you also had the Ava-Pearl trial, which looked at platinum doublet, right? And this platinum doublet was pemetrexed in this particular trial, plus bevacizumab, followed by bev plus pemetrexed versus bev alone. And here, once again, bev plus pemetrexed showed a PFS benefit. So we had various maintenance approaches, right? We had continuing the same drug, either as gemcitabine, pemetrexed, or bevacizumab. We had switching the drug, right, to either pemetrexed or bevacizumab. We had combination maintenance, right? And that showed PFS benefit in both the Atlas and Avapearl trials. So those are the maintenance strategies that were used. Improve upon this docetaxel, right, by adding other agents to it. So we had the Revel trial, which looked at docetaxel plus ramucirumab. Ramucirumab is a VEGF-R inhibitor. It is given at a dose of 10 mg per kg every 3 weeks. Okay, and this compared this combination with docetaxel alone, and there was a PFS and OS benefit to adding ramucirumab. So that was the Revel trial. And then there was something called the Loom lung trial, which compared docetaxel plus nindidanib, 200 mg BD. So nindidanib is yeah. So that is basically an FGFR inhibitor, right? So this is the Loom lung trial, and it showed a PFS and OS benefit, right? But there was extensive side effects that were seen due to toxicities. This is not currently preferred. So usually we stick to either single agent docetaxel or to the Revel trial. Okay. Apart from this, in the second line setting, they've also tried, there's a Tropion lung trial, which looked at datapotamab, deruxtecan, right, versus docetaxel alone. And this has also shown a PFS benefit. It's not approved yet, but it has shown a PFS benefit. So the second line agents are DOSI alone, DOSI plus ramucirumab, or dato deruxtecan. Both these are approved. This is pending approval. So those are the second line agents that we use in the chemotherapy era. So this is what we had in the treatment of lung cancer. We had platinum based doublet. We had maintenance, which is either continuing the same drug or switching over or using combination maintenance. And in second line, we had docetaxel or docetaxel plus ramucirumab or datopotamab deruxtecan, which is currently not yet approved. So this is all we had for the treatment of lung cancer, actually, for especially for the non-oncogene addicted metastatic non-small cell lung cancer. And then the survival outcomes were still abysmal. It was around 8 to 12 months max, and that was it. So what revolutionized the treatment of this section of lung cancer is the addition of immune checkpoint inhibitors, and that is what we're going to talk about next. So immune checkpoint inhibitors, basically you are your anti-PD-1 and anti-PD-L1 inhibitors, right? So these revolutionized the treatment of lung cancer and improved survival outcomes across the board, right? Now, the benefit from immune checkpoint inhibitors is based on your PDL1 expression. Now, PDL1 expression is assessed through various techniques. We have various scores to assess PDL1 expression. So it is done via IHC, right? Immunohistochemistry through various platforms, which I'll talk about later. And there are various scoring systems that are used to define the percentage of PDL1 expression. So we'll go through all of them. This is very important for exams. So you have the TPS score, which is the tumor proportion score. Okay. So this is the ratio of PDL1 positive tumor cells, right? Among all the tumor cells. So if you take all the tumor cells, the ratio of the PD-L1 positive tumor cells gives you the tumor proportion score that is multiplied into 100, and that is the TPS score. Now, the tumor proportion score is a score that is used in all lung cancer cases. Okay, so this is what you should remember. So lung cancer cases, we currently use the TPS score. Apart from this, you also have the CPS score, which is not used in lung cancers, but is used in a wide variety of other cancers. So this is the combined positivity score. So TPS is tumor proportional score and CPS is combined positivity score. So this is the ratio of PDL1 positive tumor cells plus immune cells. So there are many immune cells that infiltrate the tumor. So you count the immune cells that express PDL1 as well as the tumor cells divided by the total number of tumor cells into 100. So that is the combined positivity score that is used in other cancers, such as G junction cancers, and everything else, all the GI malignancies and all the other indications, such as renal cell carcinoma, bladder carcinoma, etc., or head and neck cancers, right? You use the CPS score. So that's how you measure the CPS score. You also include the immune cells as well that express PDL1. This PDL1 is always expressed as a membranous uptake. Okay, membranous uptake. So you should just remember that. Now, moving on, you also have other scoring techniques such as TC and IC score. Okay, right. So this tumor cell score is the percentage of tumor cells that show PDL1 uptake per 100 viable tumor cells. So the percentage of PDL1, the percentage of tumor cells that show PDL1 uptake amongst the viable tumor cells. Okay, so percentage of tumor cells that show PDL1 uptake amongst the viable tumor cells, and you should at least measure 100 tumor cells to give this score. So this is a TC score. This was used in earlier immune checkpoint inhibitor trials. Currently, it's not that preferred. Then you have the immune cell score, where you look at the area occupied by PDL1. So this is the area. Okay, PDL1 positive immune cells divided by the entire tumor area. Okay, so the area occupied by PDL1 positive immune cells within the tumor divided by the entire tumor area gives you the immune cell score. Okay, this is the IC score. So you have the CPS score, the TPS score, TPS which is used in lung cancer. Then you also have the TC and IC score. Then one more score that is, has been described is the TAP. This is the tumor area positivity score. This is the area covered by PDL1 positive tumor cell plus immune cell divided by the area of tumor. Okay, so this is the tumor area positivity score. So these are the five commonly used ICI based scores to look at the PDL1 positivity. Amongst all of them, TPS is used for lung cancer. Okay, so this is what they are. This some of the basics that you need to know regarding immune checkpoint inhibitors. Now, when you test for PDL1 status, you use various platforms, IHC based platforms. And there are two terms that are very important that have been defined by the FDA that is companion diagnostics and complementary diagnostics. Okay. So this is the exact word for word definition as per the FDA. Companion diagnostics provides information that is essential for the safe and effective use of corresponding therapeutic product. So it gives essential information that is required for the safe and effective use of corresponding therapeutic product, right? For example, pembrolizumab, the companion-based diagnostics was DACO 22C3. Okay, so that is the definition, and this is an example. Then complementary diagnostics identifies, this is the exact definition, identifies biomarker defined subset of patients with different benefit risk profiles for which a therapeutic product is indicated, but is not a prerequisite for receiving the therapeutic product. So that is what complementary diagnostics is. It gives additional information that that particular therapeutic product might benefit that particular patient population. So I'll repeat the definition. It identifies a biomarker defined subset of patients with a different benefit risk profile than the broader population for which a therapeutic product is indicated, but is not a prerequisite for receiving the therapeutic product. So it is complementary, but not essential as such. So, for example, in pembrolizumab, you can also look at the PD-11 score based on another scoring system such as DACO 288, for example. Although this is not the companion diagnostics, it is complementary. It can give some addition. It can give a possible benefit from pembrolizumab, right? So that is the difference between companion and complementary diagnostics. Now, let us look at the drug-specific platforms. So when certain drugs were approved, there were specific platforms for each drug, right? So you had the DACO 288 platform, and this was for nivolumab. Then you had the DACO 22C3 platform, which is for pembrolizumab. So these are the companion platforms, right? This is the approved platform that for that particular drug. Then you had Ventana SP263 for durvalumab, and you had Ventana SP142 for atezolizumab. So these are the approved platforms for that particular drug or the companion diagnostic technique for that particular drug that were used in the trials for these particular agents, right? But then there could we interchange these platforms? Can we use a particular platform for any drug? So that was a question that was being asked, and that is where we have the blueprint and ring trials. Okay. So the blueprint 1 and 2 trials. So there were 2 trials regarding this. They looked at 4 platforms. So 22C3, 288, SP142, and SP263. And what they found was that you could interchange between these 3 platforms, and they had excellent concordance for the TPS scores for the staining of tumor cells, right? Between these 3 platforms, regardless of the drug you use. Only platform that was not interchangeable was SP142, which showed in the variability in the tumor cell staining, which is why you can interchange between all the 3 of these platforms, but not with SP142, which can underestimate the tumor cell staining. Okay, so that is what the blueprint 1-2 trial showed. Also, there was a ring study which looked at interchangeability between SP263 and 22C3, and they found that both were interchangeable with good concordance between both platforms. So regardless of the drug you're using, right, it doesn't matter what platform you're using, unless it's SP142, which underestimates TC staining, you can interchange between any of these platforms. That is what these trials have shown us. So the platform as such doesn't matter in this day and age, is where we have come to currently with the current data. So now we come to the all important ICI based treatments. I'll give you a quick refresher. So main 2 ones are PD1 and PDL1, right? So PD1 is located on the PDL1 is located on the tumor cell, and PD1 is located on the T cell, right? And the interaction between both these agents leads to immunosuppression and prevents the T cell from causing what do you call it? cell death or uh, death of the cancer cell. So it prevents that interaction when both these two receptors interact. So that is why we have targeted therapies that inhibit both these receptors. So first, these were approved in the second line setting. So let's look at how that evolved. So you had nivolumab. This was based on Checkmate 017 and Checkmate 057, right? Regardless of the TPS score, they compared nivo versus docetaxel. And there was an OS benefit in both these trials, right? And therefore, nivolumab was approved in the second line setting, regardless of the TPS score. Then you also had the keynote. So for pembrolizumab, you had keynote 010 trial, which looked at pembro versus docetaxel. And this is exclusively in patients with TPS greater than 1%. Okay, so this trial included only patients with TPS greater than 1 or more. And here also, you saw an OS benefit in the second line setting. Now, the third drug that was approved in the second line setting was atezolizumab. And this was based on the popular and the oak trials. Okay, so both these trials, regardless of the TPS score, looked at atezo versus docetaxel. And both these trials showed OS benefit versus docetaxel, regardless of the TPS score. Okay, so these three drugs, that is nivolumab and atezolizumab, were approved regardless of the TPS score, and pembrolizumab was approved with TPS score greater than 1 or more. Okay, in the second line setting. Then naturally, we move towards ICIs move towards the first line. So in the first line setting, ICI was tried alone initially, right? So this was in with the keynote. So initially was for pembrolizumab. We had the keynote 024 trial, which looked at pembrolizumab 200 mg 3 weekly versus platinum based doublet. And this trial included patients with TPS score greater than 50%. Okay, and what we saw was a PFS benefit and a OS benefit, almost a doubling of OS, 30 months versus 14.2 months. And therefore, pembro alone was approved in patients with TPS greater than 50 or more. Then you had, so you had the IM Power 110 trial, which looked at atezolizumab, right, in patients with TPS greater than 1 or more. So they compared atezo with platinum doublet, and they saw not in the entire patient group, but in TPS score of greater than 50% in that patient subgroup, they saw OS benefit. So atezolizumab alone became approved in TPS score greater than 50% as first line agent. Then apart from all this, there was a third agent, that is cemiplimab, which is an anti-PD-1 inhibitor. So that was based on the Empower 1 trial. So this was only done in patients with TPS score greater than 50%, and in all patients of metastatic non-small cell lung cancer. And in this patient population in which the trial was done versus chemo alone in the first line setting, cemiplimab showed a PFS and a OS benefit. Okay. Now, another thing to note here is that in all the trials currently, the duration of ICI was 2 years. Okay. We have data to show that when you continue beyond 2 years, there might not be much benefit of continuing beyond 2 years, apart from added toxicity. So in most real world settings, we stop at 2 years and then we give the patient an option of continuing beyond 2 years. Okay. So these are the three drugs that were approved in first line setting for TPS score greater than 50% or more. That is pembrolizumab based on the Keynote 024 trial, atezolizumab based on the IMpower 110 trial, and cemiplimab based on the Empower 1 trial. All three were approved alone in TPS score greater than 50% or more. Now, the next set of trials looked at dual checkpoint blockade. Okay. So the first trial in this setting is Checkmate 227, which looked at Nivo plus IPI combination. They compared that with platinum doublet. This trial also had a nivolumab alone arm, but they did not release the survival data for that. And basically, what they found, this is regardless of TPS score. And what this trial found was that, regardless of the TPS score, there was a OS benefit that was seen. Whether your TPS score positive or negative, uh, an OS benefit was seen in metastatic non-small cell lung cancer patients in first line setting by giving nivo-ipi. Here, nivo is given at a dose of 3 mg per kg, 2 weekly, and ipilimumab was given a dose of 1 mg per kg, 6 weekly. And this is given for a total of 4 doses. And then you switch over to nivo maintenance alone, right? This currently nivolumab is currently we don't give this per kg dose. We currently give a fixed dose of 240 mg. Okay, 2 weekly. That's earlier on that dose was 2 mg per kg every 2 weeks, but 3 mg per kg every 2 weeks. But that has now changed to a fixed dose of 240 mg. So that is in that trial, but currently we give that dose. So there was an OS benefit in all metastatic non-small cell lung cancer patients, regardless of TPS, with nivo-ipi combination versus platinum doublet. Now, other, the CTLA4 and anti-PD1, PD-L1 combinations were tried. This is ipilimumab is a CTLA4 inhibitor. So another CTLA4 inhibitor in the form of tremelimumab was tried with durvalumab. So durvalumab plus tremelimumab versus chemo. There were two trials. There was the Mystic trial and the Neptune trial. Both trials were negative. So the only approved dual checkpoint blockade is currently nivo and ipi, regardless of the TPS score, based on Checkmate 227. Now, then we looked at the obvious thing, that is combining ICI plus chemotherapy. So, of course, we know that ICI because of the tumor microenvironment, most of the tumors don't have immune cells infiltrating the tumors. So basically, when you give ICI, it might not be of much benefit. But when you add chemotherapy, it breaks down the tumor cells, it releases neoantigens and causes more immune infiltration into a cold tumor. So basically, what happens is you have a cold tumor, very few immune cells, right? But when you give chemotherapy, it releases neoantigens into the bloodstream, which causes immune cells to infiltrate the tumor, to get activated by interacting with the neoantigens, and then these immune cells then go and infiltrate the tumor. So now this tumor is got more T cells, and the immune checkpoint inhibitors can act much better because more immune cells have infiltrated the tumor than was there previously due to the release of neoantigens. So that's how chemotherapy is synergistic when combined with ICIs. Okay, so now let's look at each ICI that was approved with chemotherapy. So you have pembrolizumab, right? And initially, this is based on the histology now. There were trials conducted separately. Unlike the previous trials, there were trials that were conducted separately based on the histology. So for adenocarcinoma, you had the Keynote 189 trial, which looked at pembro plus platinum plus pem for 4 cycles, followed by pembro plus pem maintenance, right? And this was continued for up to 2 years. This is compared with chemo followed by chemo maintenance alone. And what did they find? They found that there was a PFS and OS benefit regardless of the TPS score. Okay, so regardless of the TPS score, there's a PFS and OS benefit. Then you had a similar trial in squamous cell carcinoma, which is the Keynote 407 trial. Okay, so that looked at platinum plus taxane, that is, they used either paclitaxel or nab-paclitaxel, plus pembrolizumab. So pembrolizumab was given at a fixed dose of 200 mg 3 weekly, right? 200 mg 3 weekly. And they compared it with chemotherapy alone, followed by, and the pembro arm, they gave pembro maintenance, right? And in this setting as well, regardless of the TPS score, there was a PFS and OS benefit, regardless of the TPS score. So in both adenocarcinoma, you had the Keynote 189 trial, and in squamous cell carcinoma, you had the Keynote 407 trial, and both trials showed that combining ICI with chemotherapy, followed by ICI maintenance, led to a PFS and OS benefit, regardless of the TPS score. So there's no bearing of TPS score on these results. So that was pembrolizumab. Now, the second drug that was used in combination is atezolizumab. So the atezolizumab trials were only done in adenocarcinoma. There's no atezolizumab trial in first line setting that is done in squamous cell carcinoma. So you have two trials, the IMpower 130 trial, right? So this looked at atezolizumab. So regardless of TPS score, it looked at atezolizumab, 1200 mg 3 weekly plus platinum plus nab-pacli versus chemo alone. And in atezo arm, you give atezo maintenance. And this showed that there was PFS and OS benefit that was seen. Okay. Regardless of the PDL1 score, there was PFS and OS benefit that was seen. This is the IMpower 130 trial. Now, you had another trial for atezolizumab called the IMpower 150 trial. And in this trial, they gave atezolizumab, bevacizumab, carboplatin, and paclitaxel versus, yeah, so they gave this quadruplet combination versus ACP versus BCP. And regardless of TPS score in adenocarcinoma, so both the atezolizumab trials are done only in adenocarcinoma. And what did it show? It showed basically it showed a PFS benefit as well as an OS benefit with the addition of this quadruplet therapy versus both these therapies alone. Okay. So ABCP is also an approved regimen for first line setting, regardless of TPS score in adenocarcinoma patients. So this is the ICI-based chemotherapy combinations. So before we wind up, there are a few more combinations that have been tried. Right. So you also have the Checkmate 9LA. So the Checkmate 9LA trial looked at Nivo, which was given 360 mg 3 weekly plus ipilimumab, which is given 1 mg per kg 6 weekly, right? This was combined with platinum doublet. So this trial was done in all metastatic non-small cell lung cancer. So unlike the last for pembro and atezol based chemo combinations, which is done in histology specific trials, this was done in all patients, and this was compared. So this platinum doublet was only given for 2 cycles here. So that's what you have to realize. Only 2 cycles of chemotherapy was given, and following that, you continued with nivo and ipi. Unlike the Checkmate 227 and other nivo ipi trials, you continued with both nivo and ipi. Okay. So this is compared with chemo alone. And this trial showed a PFS benefit and an OS benefit, regardless of TPS score. This trial also had excellent outcomes for patients with baseline brain mets. So those patients had a OS of 19.3 months versus 6.8 months, nearly tripling. And it showed, and subgroup analysis showed excellent benefit in smokers as well. So baseline brain mets and smokers benefited really well from this. ICI doublet plus chemotherapy. Chemotherapy is only given for 2 cycles. ICI doublet is continued till progression versus chemotherapy alone. So this is continued till progression or up to 2 years. Okay, generally we give ICIs for 2 years. In this trial, it was still progression, but generally in practical setting, we give till 2 years. So this is ICI doublet plus chemo versus chemo alone, which showed a PFS OS benefit regardless of TPS score. Patients with baseline brain mets and smokers benefited the most. And it's a good regimen to use in elderly patients here. So this can be considered in elderly patients. Now, continuing with the chemo ICI combinations, we just have a couple more. So we have Empower Lung 3 trial, which looked at semiplimab 350 mg 3 weekly plus platinum doublet versus platinum doublet alone. Semiplimab arm was followed by semiplimab maintenance. And this was done in all cases of metastatic non-small cell lung cancer. And this was done in patients of all TPS scores. Okay. And here there was OS and PFS benefit in adeno and squamous cell carcinoma in all patients with TPS score greater than 1%. So the approval was only for TPS score greater than 1%. That is semiplimab and chemotherapy combination, right? So benefit is only seen in patients with TPS score greater than 1 or more, unlike the other ICI and chemotherapy combinations. That's the Empower Lung 3 study. Now, coming to the last chemo plus ICI combination, you have the Poseidon trial, which looked at durvalumab, 1500 milligram plus tremelimumab, 75 milligram, which is given 3 weekly into 4 cycles. And this is combined with platinum doublet, right? Versus platinum doublet alone. Right? So unlike the checkmate 9LA trial, which looked at ICI doublet plus chemo, this also looked at ICI doublet plus chemo. And here you continued with Durva maintenance. Okay. Okay. Right. So in this particular trial, what did they see? Basically, what they found was that durvalumab plus tremelimumab plus chemotherapy showed a PFS and OS benefit regardless of the PDL1 score in adeno as well as squamous cell carcinomas. So that is the Poseidon trial in which durvalumab plus tremelimumab is approved regardless of PDL1 score in squamous and adenocarcinomas. So let us just give a quick overview of the management in case of adenocarcinoma and case of squamous cell carcinoma. We'll start off with adenocarcinoma, right? So in PDL1 greater than 50%, you have pembro, you have atezolizumab single agent, or you can give semiplimab single agent. In PDL1 greater than 1%, you can give pembro plus platinum doublet, right? Followed by PEM maintenance. Or you can give atezo plus platinum doublet, followed by atezolizumab maintenance. You can also give ABCP regimen, right? You can give nivo plus ipi plus chemotherapy. You can give nivo plus ipi alone. You can give semiplimab plus chemotherapy. And of course, you can give durvalumab plus tremelimumab plus chemotherapy and nivo-ipi alone. So we have talked about all these trials, right? So This would be the Keynote 189 trial. This will be the IM Power 130 trial. This is the IM Power 150 trial, right? This is the Checkmate 9L8 trial. This is the Checkmate 227 trial. This is the M Power 3 trial. This is the Poseidon trial. Yeah, we already discussed, we've repeated that, right? So these are all the approvals for PD-L1 score of greater than 1%, right? In adenocarcinoma, PD-L1 greater than 50%, we have Pembro, atezolizumab, and cemiplimab, single agent monotherapies. PD-L1 greater than 1%, you can have all these chemo ICI combinations. Okay, now PD-L1 zero, we know that all these, so this is what the guidelines say. If you take NCCN, if you take ESMO, PD-L1 greater than 50%, this is what you give. PD-L1 greater than 1%, this is what you give. So PD-L1 zero, what you give. All these trials had approvals for PD-L1 zero as well. So you can, although the guidelines don't explicitly state it, for PD-L1 zero, you can still consider giving chemotherapy plus uh, ICI combination, right? And in almost all the trials, there was benefit regardless of PD-L1 status of ICI plus chemo combination, except for maybe the IM Power 3 trial. All the other trials had benefit regardless of TPS or PD-L1 expression. So for PD-L1 zero, although the guidelines don't explicitly mention it, you can still give ICI plus chemo combination. So that is what the standard of care has come to be in adenocarcinoma. Now, in squamous cell carcinoma, what is the difference? So we'll cut this out. This squamous cell carcinoma, what do we do? So it's pretty much the same, right? So you can give PD-L1 greater than 50% more. You can still give Pembro, Atezo, or cemiplimab, right? In PD-L1 greater than 1%, you can give Pem plus platinum doublet based on the Keynote 407 trial, right? These two regimens are only in adenocarcinoma, so these two we can cut out. They cannot be given in squamous cell. Nivo plus chemo, Nivo plus ipilimumab can be given in squamous, right? Similar plus chemo we can give in squamous, and durvalumab plus tremelimumab plus chemo you can also give in squamous. So apart from the atezolizumab based regimens, you can give all these other ICI plus chemo regimens in PD-L1 score greater than 1% in squamous as well. In PD-L1 score of 0, you can still consider these doublet regimens because the trials have shown benefit regardless of TPS score, right? So that is the treatment of squamous cell carcinoma as well. Only difference is ABCP and atezolizumab based regimens are not given. Now, we'll end this talk with what about patients with poor performance status? So, should we give single agent chemo or should we give ICI? So, there's something called the Ipsos trial, which compared in patients with ECOG 2-3 status, great or greater than 70 years of age, right, with contraindication to platinum doublet. So, if any of these criteria are met, that is ECOG 2 or 3, greater than 70 years of age, or contraindication to platinum doublet, so atezolizumab single agent was compared with single agent vinorelbine or single agent gemcitabine. And regardless of the TPS score, there was a OS benefit that was seen. 2-year OS was 24 versus 12%. So in unfit patients with PS of 3 or 4 or greater than 70 years of age or contraindication to platinum doublet, in all these groups, you can consider giving single agent atezolizumab. It has a benefit over giving single agent chemotherapy alone. Okay, so that is for these unfit patients. So that brings us to the winding up the management of non-oncogene addicted metastatic non-small cell lung cancer. Of course, in the second line setting, you give docetaxel, ramucirumab plus docetaxel, etc. Right? So you continue with the other treatments that we've spoken about earlier. So this is the standard of care currently for non-oncogene addicted metastatic non-small cell lung cancer. I hope you had a fruitful session. Please ask me any doubts in the WhatsApp group. I'll gladly answer them.